Concepts of Oncology, a channel dedicated for teaching about various cancers of body. A 56-year-old female patient presented with complaint of painless lump in right breast since 3 months. Lump progressively increased in size and reached about size of orange. No history of any other lump elsewhere. There is history of occasional blood-stained discharge from nipple. No history of any skin changes. 56-year age suggests patient is either peri or postmenopausal. An important history is that lump is painless. 3-month history is generally a short history. Lump progressively increased in size. No history of any other lump in body elsewhere. Blood-stained discharge suggests pathology has involved lactiferous ducts also. No history of any skin changes suggests no ulcer. Redness on skin. On local examination, a lump is present in outer quadrant of right breast 5 by 4 cm in size. Mobile, non-tender. Podarunge is present over lump. Podarunge is skin edema due to lymphatic blockage with hair follicles appearing as tiny pits leading to appearance like skin of orange. Lump is not fixed to pectoralis major muscle. Involvement of pectoralis muscle does not upstage disease and it can be removed along with breast if involved. Chest wall includes serratus anterior muscle, ribs and intercostals. Freely mobile lump in outer quadrant excludes chest wall involvement. Because of podarunge, it is clinically staged T4B. There are 2 nodes palpable in right axilla, largest 2 cm in size, mobile, firm, non-tender in central compartment. No supraclavicular lymph nodes palpable. Supraclavicular nodes means N3 disease, however they are absent in this case. Axillary nodes whether single or multiple are CN1, if they are mobile. Systemic examination normal means there are no clinical signs of distant mets, so it is clinically M0. What is the first step? Since this is CT4BN0M0 so it comes under locally advanced breast cancer which is defined as T3N1 and beyond. So according to triple assessment, after history and physical examination comes imaging and pathology. Next step, hence will be imaging as biopsy before imaging may affect reporting due to hematoma and edema plus mammography involves compression of breast so after biopsy, it may be painful. X-ray mammography is the main investigation and it must be done bilaterally to exclude synchronous second primary in opposite breast. Breast MRI is not indicated in this case, it is reserved for screening of high-risk familial cases and when mammography is indeterminate. Breast USG is used as an adjunct to mammography. How will you perform biopsy? Biopsy is done usually by core cut biopsy technique using core cut gun. If core cut gun is not available then incisional biopsy is done. Biopsy is preferred over FNAC as it provides vital information necessary for instituting neoadjuvant treatment. However, FNAC is done for lymph nodes. Mammography shows BIRADS 4 abnormality and biopsy confirms malignancy. Infiltrating ductal carcinoma NOS. Estrogen receptor negative. Progesterone receptor positive. HER2 negative and Ki67 40%. Ki67 indicates proliferation index. Higher the value, more aggressive the tumor is. What is the molecular classification of tumor? It is neither triple negative, nor HER2 enriched. It is luminal variety. Luminal A and B are differentiated by Ki67. Both are hormone positive and HER2 negative. Higher Ki67 is a feature of luminal B. How will you do metastatic workup? Since this is locally advanced breast cancer so detailed workup is needed. Either chest, abdomen CT with bone scan is done or some clinicians may proceed directly with PET scan. Brain MRI is indicated when symptoms or signs are suggestive of CNS mets. PET scan is not sensitive for brain mets as whole brain always appears a hot spot in PET scan. With no mets and nodes positive, what is the next step? In LABC, due to risk of micromets, treatment is started with neoadjuvant systemic therapy in form of chemotherapy. Neoadjuvant hormonal therapy is indicated in elderly women with hormone-positive tumor, but not fit for chemo. Neoadjuvant targeted therapy is Herceptin treatment but this tumor is HER2 negative. Patient was put on chemotherapy, epirubicin based for 4 cycles and podarunge disappeared with lump reducing to 2 cm in size. What is next step? Both options are correct, as there is partial response so one may finish all 8 cycles of chemo before surgery. This approach is more effective in TNBC and HER2-enriched tumors, where achieving pathological complete response is more likely to happen. In this hormone-positive tumor, chances of PCR is less likely, hence many clinicians would prefer to go for surgery after 4 cycles of chemo. Patient and surgeon agreed on doing MRM, then comes reconstruction. Option C is wrong, as reconstruction does not delay diagnosis of recurrence, as most recurrent nodules are present on skin and subcutaneous tissue. Option B is also not right, as it is not mandatory to do delayed breast reconstruction. Early reconstruction can be done and is often preferred, as it avoids mental trauma to patients by preventing her from living with mastectomy done. She wakes up with reconstructed breast. Taxane chemo was started for next 4 cycles. What is correct? Option A is wrong, as hormonal therapy is avoided with chemo. Hormonal treatment decreases rate of proliferation, while chemo has more effect on rapidly dividing cells. Radiation is given separately, not with adjuvant chemo. Chemo given during radiation is not adjuvant chemo, but only given as radiosensitizer. Herceptin cannot be given, as tumor is HER2 negative. Chemo is given alone. After chemo, patient is given radiation. Which field will not be included in radiation? Axillary radiation is avoided after breast surgery. It is given only in at-risk axilla, like incomplete dissection. Extranodal extension positive. Rest fields given are chest wall, infraclavicular, supraclavicular, internal mammary. After radiation, next plan, bilateral oophorectomy alone is not done. Letrozole is aromatase inhibitors, but it cannot be given unless patient is menopausal. Functioning ovary overcomes action of aromatase inhibitors. Tamoxifen can be given for 10 years. Better would be to give tamoxifen for few years and then switching to AI when patient attains menopause.